All right, let's dive straight into this rapid-fire explainer on viral encephalitis. We're cutting out all the fluff today. We're focusing strictly on those high-yield clinical findings, the sneaky diagnostic criteria, and the exact pathogen patterns examiners absolutely love to go after. If you're looking to crush the neuro ID section of your board exams, you are in the exact right place. We've got a packed syllabus today. We'll be moving systematically through the heavy hitters, from HSV, arboviruses, PML, SSPE, rabies, all the way to a really critical clinical plot twist at the very end. Now, before we hit the specific bugs, lock this general rule into your brain. You're going to consistently see a lymphocytic pleocytosis, meaning a bumped up white count driven by lymphocytes, along with mildly elevated protein. But the anchor point, the absolute first thing you must check in any vignette, is the glucose. If the CSF glucose is low, that's a massive red flag. It's highly unusual for a virus. Right then and there, you need to pivot and start hunting for bacterial, fungal, or tubercular meningitis. Normal glucose, that's your viral suspect. Section 1, HSV, the must-know heavyweight. So, HSV is the undisputed heavyweight of the group. It's the most common cause of sporadic, fatal encephalitis in healthy adults. It's your classic frontotemporal encephalitis, right? Think olfactory hallucinations, bizarre behavior, memory issues. Now, while CSF PCR is the absolute gold standard for diagnosis, let's hit a rapid-fire question that trips up a lot of people. What is the characteristic EEG finding in HSV encephalitis? Well, here's your answer. You are looking for periodic, stereotyped, sharp and slow complexes originating specifically in the temporal lobes, repeating at 2 to 3 second intervals. When you spot this precise temporal lobe pattern between days 2 and 15 of an illness, you need to anchor onto HSV immediately. It shows up in about 2/3 of pathologically proven cases. So if a vignette describes a patient with a fever, bizarre behavior, and this exact EEG tracing, don't even wait for the PCR. You suspect HSV right on the spot. Okay, let's talk treatment. Why is acyclovir the drug of choice, and how does it work so elegantly? Well, acyclovir is brilliantly selective. Why? Because uninfected cells literally lack the viral thymidine kinase needed for that first crucial step. It's like the virus hands the drug the key to its own destruction. The viral thymidine kinase phosphorylates the drug into a monophosphate, and then host enzymes jump in and finish the job, converting it into a triphosphate that aggressively shuts down viral DNA polymerase. Since healthy cells don't have that initial viral kinase, they completely ignore the drug. Now, the crucial point here is the dosage and, more importantly, the duration. You're hitting adults with IV acyclovir at 10 milligrams per kilogram every 8 hours for a full 21 days. That's a 21-day minimum course to prevent relapse. Seriously, keep your eyes peeled for trick questions offering shorter durations on multiple choice options. Moving on to Section 2, arboviruses, focusing on West Nile encephalitis. Shifting gears to a different season and vector, let's look at the most common arboviral CNS disease in the US since 2002. Usually for viral encephalitis, we immediately want the PCR, right? But here's a classic rapid-fire twist. For West Nile, why is the CSF West Nile virus IgM actually preferred over the PCR? It's super easy to get tripped up here because, unlike with HSV, PCR is actually less sensitive in this specific scenario. And the reason brilliantly illustrates the concept of intrathecal synthesis. See, IgM is a massive molecule. It physically cannot cross an intact blood-brain barrier. So if you find West Nile IgM floating around in the spinal fluid, you know it didn't just leak in from the blood. It was manufactured right there, inside the central nervous system, which is absolute proof of active CNS infection. By day 7, this IgM test hits 80% sensitivity, completely blowing the PCR out of the water for West Nile. So what kind of clinical breadcrumbs will the exam drop for you? Well, if your patient shows up in late summer, think August or September, and their MRI shows deep gray matter involvement like the thalamus or basal ganglia, you better be thinking West Nile. Clinically, this looks like movement disorders, a brand new tremor, Parkinsonism, or myoclonus. And here is probably the highest yield clue of the bunch, a poliomyelitis like acute flaccid paralysis. If you see asymmetric weakness with absent reflexes in the dead of summer, West Nile needs to be at the absolute top of your differential. All right, Section 3, PML and the JC virus. This brings a really fascinating shift from an acute, fiery encephalitis to a chronic progressive demyelination. PML is caused by the JC virus waking back up in immunosuppressed patients. Now, while AIDS is the most common immunosuppressive setting overall, examiners absolutely love testing drug-induced PML. So here's the question. Which MS or inflammatory bowel disease drug carries the highest risk of triggering PML? The answer you're looking for is natalizumab. This is an extremely high-yield pharmacology tie-in. Natalizumab is a monoclonal antibody against alpha-4 integrin. Essentially, it works by blocking lymphocyte trafficking into the CNS and the bowel mucosa. Now that's fantastic for halting MS flares, right? But by keeping the immune system's bouncers out of the brain, it gives the latent JC virus the perfect opportunity to wake up and wreak havoc. It carries an overall risk of roughly 4 cases per 1,000 treated patients. So how exactly does PML present? Keep in mind that PML demyelinates the white matter of the brain, which leads to visual deficits, mental impairment, and hemiparesis. But here's the kicker you need to remember. It typically spares the spinal cord and the optic nerves. If you're looking at an MRI of an HIV patient, these lesions are classically non-enhancing. And sadly, as of right now, there's no proven antiviral treatments. The only effective strategy is trying to restore immune competence, like starting antiretroviral therapy for HIV patients or immediately stopping the offending drug.
Next up, Section 4, SSP, the measles latency.
When we look at this terrifying complication of a vaccine-preventable disease, the timeline we're tracking is a classic high-yield board fact. Stage 1 is an early measles infection, usually happening before the age of 2. Then comes this silent, latent period lasting roughly 6 to 8 years, where a chronic, non-permissive infection just slowly smolders away in the brain. Finally, usually between the ages of 5 and 15, the child starts experiencing progressive neurologic deterioration. It often begins super subtly, maybe a drop in school performance or minor personality changes, but it relentlessly progresses to seizures, ataxia, and eventually a quadriplegic, unresponsive state.
Moving on to Section 5, rabies, the fatal bite.
Okay, let's talk about a virus that is virtually always fatal once symptoms appear. We need to compare the two distinct clinical presentations of rabies. While classic dog bites worldwide tend to cause the furious form, which is characterized by intense water spasms, hydrophobia, aerophobia, and autonomic hyperactivity, you have got to remember that in the USA, the primary risk factor is actually bat exposure. And bat exposure often leads to the paralytic or dumb form of rabies. This presents as an acute ascending paralysis that almost perfectly mimics Guillain-Barré syndrome. And the most terrifying part? Sometimes there is absolutely no clear history of a bat bite. Seriously, just finding a bat in the room of a sleeping person is enough to trigger full post-exposure prophylaxis protocols. So how exactly do we nail down a diagnosis when the clinical picture is blurry? When serology is predictably negative during that crucial first week of symptoms, you're going to need tissue to confirm it. What is the highly specific biopsy site used to detect the rabies virus antigen? It's a skin biopsy from the nape of the neck. Using immunofluorescence to hunt for the viral antigen in the neural innervation of the hair follicles right at the nape of the neck is a classic, screenshot-worthy trivia fact for your exams. It perfectly illustrates the pathology. The virus travels retrogradely along peripheral nerves, straight to the CNS, and then spreads back out to highly innervated areas, like hair follicles and salivary glands. Finally, Section 6, the autoimmune mimic. We are wrapping up with a modern clinical plot twist that completely tests your ability to overcome anchoring bias in the ICU. Check out this staggering statistic. Up to 25% of patients who actually survive an initial bout of HSV encephalitis will go on to develop anti-NMDA receptor antibodies. Essentially, they develop a secondary autoimmune encephalitis.
Which leaves us with this final, provocative scenario. When an HSV patient successfully finishes their 21-day acyclovir course, begins to improve, and then suddenly crashes with new psychiatric symptoms, seizures, or movement disorders, are you treating a resistant virus? Or are you looking at a new autoimmune mimic? Because if you blindly assume it's acyclovir resistance and just hammer them with more antivirals instead of checking the CSF for autoantibodies, you are going to completely miss the true diagnosis. The mimic requires immunosuppression, not antivirals. So as you head into the wards or sit for your exams, how will you adjust your clinical thinking to make sure you catch the mimic? Keep that question in mind. Happy studying.